dynamic consistency or constancy or homeostasis of the internal fluid environment within normal limits. So the kidneys are going to make sure that, the proteins stay in the blood. They're going to make sure that we have just the right amount of sodium in the blood. Their job, even though they're not that big, it's so important. So each kidney processes incoming blood plasma in ways that allow it to leave the kidney in better condition. And remember I said last week, you want to think of the kidneys as a plumbing system, not just for urine, but for blood as well. Okay, it's going to do both. The water content is adjusted so that the body does not have too much or too little water to maintain constancy of the internal environment. The excreted urine travels from the kidneys to the outside of the body via accessory organs, and you want to know what the accessory organs are. The ureters, the urinary bladder, and the urethra. So I want you to know we have two ureters. We have one that goes from each kidney to the urinary bladder. So we have a ureter for the left kidney, and we have a ureter for the right kidney. And they both go to the urinary bladder. And from the urinary bladder, we have the urethra, which will carry the urine out. We'll carry it the rest of the way. So we have one urethra. One urethra. So here is, on slide 4, this is an excellent visual of the kidney. So if we start at the very top, you see those adrenal glands that lie on top of the kidneys. And what's the adrenal's function? We learned this in the endocrine system. What's it secrete? What hormone? What adrenaline. Adrenaline. Very, very good. And then we have our two kidneys. You wonder why the kidneys are so vascular. Well, look what's going on here. We have the renal artery and the renal vein that is supplying the kidney with blood. Okay, renal artery and renal vein. We also have coming off, we have the abdominal aorta. The abdominal aorta is of clinical significance because a patient can suffer an aneurysm there. Even if they're in the hospital and they suffer an abdominal aneurysm, it's a very, very poor prognosis, even if it happens in the hospital. Inferior vena cava, we have the ureters that I was talking about, one on each side going to the bladder, and then we have the urethra. Now I'm going to go into more detail about the urethra in a minute, but because there's differences between the male and the female, so we'll talk about that. Kidney, the size, shape, and location. You want to know that the kidneys lie on either side of the vertebral column between T12 and L3. T12 and L3. That's why my nurses, when patients have problems with their kidneys, where do they feel the pain? In the lower back. Renal fascia anchor the kidneys to surrounding structures. And I want you to highlight this next one in your notes. Each kidney is surrounded by a renal fat pad. And it's a very heavy cushion of fat that helps protect each kidney. Okay, and you'll see it on the cat. You'll actually see fat around the cat's kidneys. And it's for protection. You want to know that the left kidney is often slightly larger than the right. And the right kidney is located slightly lower than the left. Now, you know, this would be textbook perfect. It's not always like that. You know, sometimes the right kidney is a little larger, sometimes they're the same. Doesn't matter, okay? Unless there's a pathology that's causing one of the kidneys to swell, you know, we don't worry about that. Okay, it's not a pathology if one is slightly larger than the other. The kidneys lie in a retroperitoneal position. You want to highlight that, meaning posterior to the parietal peritoneum against the posterior wall of the abdomen. So you want to know that whole sentence there. The hilum is a concave notch on the medial surface where vessels and tubes enter the kidney. I want you to highlight that in your notes, please. I'll have that on your quiz. Okay, on slide number 7, I do want you to know the anatomy of the kidney. The anatomy of the kidney. So if we have the kidney and we cut it in half, at the very top is going to be the capsule. That's the fibrous capsule. It's the outermost layer. And then we're going to have the cortex. So all of this, where my little red dot is all cortex. It's all cortex. In the middle is the medullary pyramids or the medulla. Remember, medulla means middle, so all this pink area is the medulla. Now, coming off of each medullary pyramid, which is, again, the medulla, you're going to have minor calyces. We talked about these last week. They're cup-like structures that collect urine. And do you see how it does look like a cup? Okay, so minor calyces are cup-like structures that collect urine. And these minor calyces actually turn into major calyces. Does everyone see that? So we have the minor calyces, and then we have the major calyces. See how they're bigger now? And I want you to know the major calyces will eventually turn into the renal pelvis. The renal pelvis. And that's this area right here. The renal pelvis. And that renal pelvis, as it moves down, it actually becomes really narrow, and it actually is going to become the ureter. Okay, the ureter. How many ureters do we have? 2. One from each kidney. So you want to keep this in order, right, in your head. So we start out with minor calyces, which go into major calyces. The major calyces will form the renal pelvis, and from the renal pelvis, it actually will turn into the ureter. Okay, I want you to know that, so please have those steps now. And this is the same picture, really. This is from a cadaver, though. So this is actually a picture of a kidney from a cadaver. And you want to think of all these renal papilla They all have real little tiny fenestrations or little tiny holes, and it's going to secrete all the urine or excrete all the urine. So renal cortex and renal medulla, we talked about the cortex. It's the outer region. It's right inside the capsule. And then the medulla is going to be the inner region. I want you to know, calyx is actually singular for calyces. So if I was talking about one, I would say the calyx of the kidney. If I'm talking about more than one, then I say the calyces. So the calyces are cup-like structures at each renal papilla that collects urine. I want you to know that. The renal pelvis narrows as it exits the kidney to become the ureter. It acts as a collection basin to drain urine from the kidney. We okay so far? Okay. And again, each renal papilla has multiple openings that release urine. Minor calyces join to form major calyces, which in turn join together to form the renal pelvis. I've already said this. Okay. Please know it for the quiz. Okay, let's talk about the blood vessels of the kidney. So we have the renal artery. The renal artery. It's a large branch of the abdominal aorta that brings blood into each kidney. Now this is a little bit different than the heart, right? Because the heart brought oxygenated blood from what? From the pulmonary what? Vein, right? Because remember, arteries carry blood away from the heart. The kidneys is a little bit different. The arteries brings blood to each kidney. You see, you want to know that. The renal artery. Interlobular arteries between the pyramids of the medulla and renal artery branches. Afferent arterioles extend to the nephrons. What are the nephrons? The nephrons are the functional unit of the kidney. You have to know this. The nephrons are the functional unit of the kidney. And we have about 1 million nephrons in each kidney. And we have about 1 million nephrons in each kidney. So what do you think happens to these nephrons when people have kidney disease? Yeah, very good. So unfortunately with nephrons, when they die, they're not replaced. Okay? However, the remaining ones will get bigger and they'll try to take up the slack for the missing ones. Okay? And it works for a while, right? Until the pathology gets worse and worse, and of course we can't keep up. So you want to think of a patient who is elderly. Let's say they're, 70. I don't like to say that's elderly because I'm not far from it, but let's just say 70. And you start seeing a little bit of a decline in their kidneys, right? That's exactly what's going to happen. The ones that are remaining are going to enlarge and it'll pick up the slack. If there's no pathology going on, it will just continue to do that. Right? Okay. It's when we have the pathologies that it can't keep up anymore. And now what's happening is that we're losing more nephrons than the ones remaining can compensate for. And that's where the problems come in. So again, here's another video just showing the circulation of blood through the kidneys. Renal artery again is going to bring the blood to the kidney. Very vascular. If you suffer a trauma to the kidney, if someone kicks you in the kidney, you're going to urinate blood. Even with that heavy fat pad around it, you're going to urinate blood. It's very painful. This I just wanted to show you, not that long ago, if someone had kidney cancer, we removed the entire kidney. We don't do that now. If we have a tumor, we remove just the tumor, we close it up, and the remaining kidney will continue to function, which is brilliant. People can live with just one kidney, but 1.5 kidney is better than just one, right? And something else I wanted to share with you, I'm not going to test you on this, but when we have to have a kidney transplant, if the diseased kidneys aren't cancerous, and what I mean by disease, they're just not working anymore, right? We leave them right where they are because they're not hurting anything. They're just not working. And we put the new kidney down here. So it's really cool. We do this for a number of reasons. Number one, whenever you have to remove an organ, it's more invasive surgery, right? Number two, if we put it down here and the body rejects the kidney, it's easy to go in, remove it, put another one back in. So that's what we do with kidney transplants. Unless, of course, it's cancer, then it's much more involved. Okay, the ureter. Tube running from each kidney to the urinary bladder. You already know that. The urinary bladder is a structure that is composed mostly of smooth muscle tissue, and it can descend considerably. So when our bladder is healthy, we can go quite a long time, right, without urinating. You can hold it. It's not good, though, to do that, right? What happens when we get older? What happens to that bladder? Yeah. So what happens? You laugh, you sneeze, you cough, and guess what happens? Yeah. Did you have to look forward to it? It's so much fun. Functions. I remember when I was a kid, I thought 30 was old. Do you guys remember that? Thinking that? I have a shirt of, saying 30 is old.
I did.
Okay,
And then I worked in a hospital.
Reservoir for urine
80s old.
before it leaves the body.
Even then, I didn't think
Okay,
it
that's
was
easy,
that.
right? What's that the function of? The bladder. Okay. It's aided by the urethra to expel urine from the body. So please know the function of the bladder is pretty self-explanatory. The ureter, I want you to highlight this in your notes real big. The ureter is composed of 3 layers. I want you to know that. It's composed of 3 layers. The mucus lining, the muscular middle layer, and the fibrous outer layer. The urinary bladder is a collapsible bag located behind the pubic symphysis. But I want you to know the first sentence there. The ureter is composed of 3 layers. Here's a nice visual on slide 17. So let's start at the very top. Here we have our kidneys, we have our bladder, we have the pubic symphysis, and we have the urethra for the female and the urethra for the male. Okay, so both for the female and the male, the urethra eventually will become the urinary meatus. So you want to put that in your notes for both the male and the female. The urethra eventually will become the urinary meatus. Now, what do you notice different? Yeah, the length. So in the female, it stops, the urethra stops right here at the bladder. So the urethra for the female is just for urination. Okay, it's just for urination. For the male, it goes from the bladder, it's actually going to go through the prostate, and it goes down all the way through the penis. So for the urethra, for the male, it's for both urinary purposes and reproductive purposes. So you want to know that in your notes. For the male, the urethra, it has dual function. One's for urinary and one's for reproductive.
You can.
So in females, the urethra is approximately 3 centimeters long, compared to the male, which is 20 centimeters long. And this says what I've already said. After leaving the bladder, it passes through the prostate gland, where it is joined by 2 ejaculatory ducts from the prostate. It extends to the base of the penis, then through the center of the penis, it ends at the urinary meatus. So, is there any other let's see, regarding the ureter and the urethra, do you see anything different with the ureter for the male? Yeah, so the ureter is longer in the male as well. Okay. So if the ureter in the female is shorter and the urethra is shorter, what does that mean for us? Yes, we have a greater chance for infection. Why is that? There's less space, right? So the bacteria comes in, and before you know it, we've got an infection. Where here, if it enters, it's got all this way to get rid of it, right? So that's another thing I want you to know. We already did this, so we're good there. What is micturition? Fancy name for urination. I don't think anyone says that. How's your micturition? I don't know. But that's what it means, okay? Let's use your. So as bladder volume increases, micturition contractions increase, and the internal urethral sphincter relaxes. The external urethral sphincter muscle contracts first, then at the appropriate time, it relaxes to release urine. And again, micturition is also called urination. Voluntary control of micturition is possible only if nerves supplying the pelvic floor, the projection tracts of the central nervous system, and the motor areas of the brain are all intact and functioning properly. Learning dysfunction is not possible until the urinary system matures sufficiently. And that's why sometimes we have different ages with potty training. Just takes a little longer. Voluntary control of urination is impossible during infancy and very early childhood. We okay? Good so far? All right. Let's get back to the nephrons. You already know that they're the functional unit of the kidney. We have about 1 million in each one. Each nephron is made up of 2 regions, the renal corpuscle and renal tubules, and connects to a shared collecting duct. So the renal corpuscle is made up of the glomerulus tucked inside the Bowman's capsule. Really, all I want you to know about the glomerulus is that the function is filtration. The glomerulus, the function is filtration. Have we already said this? Nephrons, the microscopic functional unit of the kidneys. So the glomerulus is going to have fenestrations or tiny pores in the capillary walls that permit filtration. I can't stress that enough. I want you to highlight that in your notes real big. The glomerulus permits filtration. So the glomerulus is a network of fine capillaries surrounded by the Bowman's capsule. The basement membrane lies between the glomerulus and the Bowman's capsule. And again, the function of the glomerular capsular membrane is filtration. And we're going to see this in the lab, so I'm hoping it'll make more sense when we do the simulation. And this is just showing the glomerulus surrounded by the Bowman's capsule. Overview of kidney function. What are the chief functions? To process blood and form urine. You already know that, right? Plumbing system for both blood and urine. So it does it by doing 3 things. Filtration, movement of water and protein-free solutes from plasma in the glomerulus into the capsular space of the Bowman's capsule. So this is where the filtration is going to occur. Filtration. Then we're going to have tubular reabsorption. So just think about what that says. It's reabsorbing something, right? So movement of molecules out of the tubule and into the peritubular blood. So those proteins like albumin, right? They're going to go to the kidney and then they're going to be reabsorbed back into the blood in better shape than before they got there. And then we have tubular secretion. Movement of molecules out of the peritubular blood and into the tubule for excretion. So we're going to have just the right amount that's going to be reabsorbed, and whatever needs to be excreted will be. And I'll show you how that works. So kidney failure means homeostatic failure, and if not relieved, inevitable death. And when you're treating your patients and they're in renal failure, sometimes, there's nothing we can do at the end, right? If it's less than 15% functioning, we can put them on dialysis. But usually it's just not the kidneys that are failing. What else is going on with them? Their heart. And that's a double whammy, and the medication that we use to treat the kidney disease is harmful to the heart and vice versa. So it becomes very difficult to treat both of them. The function of the glomerular capsular, well, I already said this, is filtration. Regulation of urine volume, this is so important. So the antidiuretic hormone, what's it do? Helps us retain water, retain fluid. So ADH influences water reabsorption. It reduces water loss. This is happening right now as you're sitting there. Okay, it's making sure that you have just the right amount of water, right? If it feels like that you're too dehydrated, it's going to kick in. Aldosterone, secreted by the adrenal cortex, it also does a lot with the water. We learned this from the RAS system. It does the same thing. It's going to increase the water reabsorption. So it's going to stop us from losing fluid, just like ADH. But it increases the distal tubule absorption of sodium, raising the sodium concentration of the blood, and thus promoting reabsorption of water. So you want to think of aldosterone as taking it a step further, all right? It's going to increase the absorption of the sodium. And in turn, that's going to increase the reabsorption of the water. Because remember, what does water do? It follows salt, follows sodium. Atrial natriuretic hormone, ANH, secreted by the atrial muscle fibers to promote loss of sodium via the urine. So here we have the absorption of sodium. Here we have, they're going to come in and promote the loss of sodium via the urine. So if the sodium gets a little too high in the blood, well, this ANH is going to kick in, and it's going to allow us to release that sodium from the urine. This is natural physiology. This is the way our body should work. Unfortunately, in the medical profession, you're going to see the opposite of this, right? Because the kidneys are failing, so they're not doing their job. Urine composition. So urine, believe it or not, is mostly made up of just water, okay? But it's going to have nitrogenous waste like, which is the result of protein metabolism. So it's going to include urea. You know, we want to get rid of that urea because that's a byproduct of protein. And we don't want the urea high in our blood. So we want to get rid of it through the urine. It's going to consist of ammonia, some creatinine, because again, we don't want high creatinine levels in the blood. Electrolytes, mainly the following ions. So in our urine, we're going to see sodium, potassium, ammonium, chloride, bicarbonate, phosphate, and sulfate. Toxins during disease, bacterial poisons leave the body in the urine. Please note slide 30. Urine composition. We have pigments. These urochromes will make the urine a different color. Hormones, high levels may result in hormones spilling into the filtrate. Here's what we don't want to see: abnormal constituents. We don't ever want to see blood in the urine, unless a woman's menstruating. That's different. Glucose, albumin, Cas, and caliculi. What's caliculi? It's a fancy name for stones. So urinary disorders. We can have something called renal hypertension. Yes?
Real quick, why is it when we're right, is creatinine higher?
When we're dehydrated? Because you're not urinating, because you're not taking in the fluid. So you're gonna have higher levels of creatinine. You may even have higher levels of urea, because you're not urinating it out. Now, if it's just because you're dehydrated, because you know, it's not due to a pathology, you just haven't drank anything for, you know, we see this a lot in the elderly, they forget to drink. The once we hydrate, everything will go back to normal. So renal hypertension is caused by stenosis of the renal artery. Caused by stenosis of the renal artery. Obstructive disorders interfere with normal urine flow in the urinary tract. Renal caliculi or kidney stones. Neurogenic overactive bladder is loss of normal control of bleeding. Tumors and other obstructions, we have renal cell carcinoma, bladder cancer. Both of these are really tough because with kidney cancer, we really don't have any symptoms until blood appears, right? Then we have blood in the urine, then we go get it checked out, and bladder cancer is the same way. It's usually stage 4 before we diagnose it. If we could catch it early, it would be very treatable. Sometimes though, with kidney cancer, the tumor is encapsulated, which means it hasn't metastasized anywhere, it's just in one spot. And that's the picture I showed where they can remove it, and if it's encapsulated, chances are it's not going to come back. So so-called renal hypertension is a common type of secondary hypertension that may be caused by stenosis or narrowing of the renal artery, which is often caused by an accumulation of the atherosclerotic plaque. Many caliculi develop as calcium and other minerals crystallize in the renal papilla. They break off into the urine. Sometimes we can pass these. Sometimes they use lasers and they break them up so we can pass them. Renal and bladder cancers have very few symptoms early in the development, other than traces of blood in the urine. Some more urinary disorders. Urinary tract infections are very common, more so in females. Glomerular disorders, kidney failure, failure of the kidney to properly process blood plasma from urine. Chronic renal failure, progressive condition resulting from the loss of nephrons. So on slide 35, I want you to know it very, very well. So dozens of diseases may result in the gradual loss of nephron function, including infections, diabetes, glomerulonephritis, tumors, systemic autoimmune disorders like lupus, it wreaks havoc on the kidneys, and obstructive disorders. Chronic renal failure develops in 3 stages. I want you to know these 3 stages. So stage 1, some nephrons are lost, but the remaining healthy nephrons compensate by enlarging and taking over the function of the lost nephrons. You want to know that. Stage 2 is called renal insufficiency. You want to know that. So in core, if they talk about stage 2, you're going to say that's renal insufficiency. The kidney can no longer adapt to the loss of nephrons. Stage 3 is called uremia or uremic syndrome. I want you to know that. Uremia literally means high blood urea. And this is how we test the kidneys. We do blood work, we do a renal panel, and they're going to check the urea in the blood. It's called a bun, right? They do the blood, the urea, and the nitrogen. Okay, it's called a bun, B-U-N. This stage is characterized by a very high bun, which results from the loss of kidney function. And on slide 36, I know you're gonna kill me on this one, but I want you to know the numbers. Okay, I want you to know the numbers. So we have 5 stages of kidney disease. We have stage 1, normal or high GFR. So the GFR is greater than 90. So, you know, that's pretty good. Okay, stage 1. Stage 2 is mild chronic kidney disease, CKD, chronic kidney disease. The GFR is 60 to 89. Okay, now we're seeing a substantial difference, right? You know, you want it to be over 90, now 60 to 89. Stage 3A is moderate chronic kidney disease, and the GFR is 45 to 59. Now, it has their attention. It's getting bad now. Stage 3B is moderate, 30 to 44. Now, having said this with stage 3B, you can live a long time if we can keep it there. Okay? And it depends on what's causing it. If it's uncontrolled hypertension, gotta fix it. Okay? If it's uncontrolled diabetes, have to fix it. Stage 4, severe chronic kidney disease. Now we're looking at 15 to 29. Now we're calling the patient in and we're talking to them about dialysis. Right? If they're at 29, they still have time before they'll do dialysis. But here, stage 5, less than 15, they have dialysis or they will die. There's no, they have to have dialysis.